Hello, my name is Dr. Sam Breeding. I want to talk a little bit about how HCC coding works, but before I do that, I'd like to tell you a little bit about myself. I'm a practicing physician. I have been in Houston Medical Group for the past 20 years. Houston Medical Group is a multi-specialty group that has just over 100 physicians and 40 mid-level providers. We're located in Kingsport, Tennessee, which is the northeast section of Tennessee. In January 2014, I was asked to become the Chief Medical Officer of the group. My first directive was to educate the physicians and practitioners about Medicare Advantage and HCC coding. Houston Medical Group had been in several Medicare Advantage programs over the last few years, initially starting at a no-risk 25% gain share, moving up to a 50% risk. But in 2014, we were at a full-risk 100% gain share program with one of our insurance company, and it was imperative that we executed to this contract. The problem I had was I knew nothing about Medicare Advantage and HCC coding. I'm board certified in both family medicine and occupational medicine, but I had spent the last 30 years practicing only occupational medicine. So you could ask me pretty much any question about workers' comp and I would know the answer. But when it came to Medicare and Medicare Advantage, I knew almost nothing. Fortunately, I had an excellent teacher. He was an administrator who had worked in both the insurance industry and healthcare administration side of things. And so he helped me learn about this. The problem we were having was getting the physicians to understand how these worked and how the programs were to come together and how to execute this. And so they wanted me to help be the person to educate them with this. We thought that we would start at our annual meeting that was held in March of 2014. The theme of the meeting was going to be the rules of the game. In this, we were going to talk about how the rules were changing from a fee-for-service medical practice to a pay-for-value medical practice. And as you know, Medicare Advantage is really a pay-for-value practice. My talk was to be an introduction to Medicare Advantage and HCC coding. And I must say the talk was well received because the providers were anxious to learn about this. They knew that we had an important contract and they wanted to know more about this. Well, after the meeting was over, I realized that I had to learn more. And the problem is there's no real single source of information when it comes to HCC coding. And I literally spent several hundred hours reading everything I could find on HCC coding. I did a lot of research and also talked to many coding experts to try to figure this out. So I started putting together some talks. Started with 30-minute talks that I went to each practice and did what I called lunch and learns, where the doctors would have lunch while I gave them a lecture on HCC coding. I also put together a series of talks that lasted 10 to 15 minutes that I called the HCC moments. I gave these talks at board meetings and section meetings, but still it was more of a hodgepodge type presentation of the information, and I wanted to put together something a little bit more cohesive. So I spent more time merging some of these lectures together, and I put together a comprehensive education program for providers. And this has turned into the video program called HCC Coding for Medical Advisors. Medical Providers. This is very important for our doctors to learn to do because HCC coding is going to be the lifeblood of the Medicare Advantage programs. But we've also seen that HCC coding is moving now to the major way to risk adjust programs. It's moving not only through Medicare Advantage, we actually have a commercial plan that is using HCC coding to compare how group costs compare from group to group. Also, as you may know, HCC coding is going to be used as the primary risk adjusting method for the Affordable Care Act. And so HCC coding is not going away, and the more you know about it, the better off you're going to be. So let's get started and talk about how HCC coding works. When I first started learning about HCC coding and the Medicare Advantage plans, I really had three surprises. The first surprise was that seeing more patients was not the only way to get paid more. As you know, in a fee-for-service environment, the more patients you see, the more money you make. Surprise number two is that you can get paid more for taking care of higher complexity patients. And this was something different. This went beyond the regular E and M codes, you know, the level 2s, 3s, 4s, and 5s, and that sort of thing. This actually went into how many diagnoses the patient had and how serious these diagnoses were. And surprise number three was that you actually got paid for thinking. The nice thing about being paid more for taking care of complex patients is that you get paid for thinking about this. I noticed when I was in occupational medicine that I would get paid more for sewing up a simple laceration than I would from taking care of a very complex workers' compensation case. And a lot of primary care providers realize that people who have procedures that they can charge for often get paid more. And so it's very refreshing to see that in a program like this, you actually get paid to think. So now let's talk a little bit about Medicare and Medicare Advantage. As you know, Medicare is a federal health insurance program, and Medicare consists of 4 parts. Part A is simply the inpatient part, and that's the inpatient hospital, SNF units, and things like that. Part B is outpatient. This includes doctor services, office visits, screening therapies, preventative services, lab, x-ray, even ambulance services, and things like that. Part C is the Medicare Advantage plan. It includes Parts A and B, but also includes medical plans and other things, as you'll see. Part D is pharmacy benefits, and this can vary from plan to plan. Now let's look a little bit at Part C, Medicare Advantage. That includes Part A and B services, so inpatient and outpatient services. It includes extra things in some plans, such as dental, vision, hearing, and even memberships to gym and exercise classes. Now, Medicare Advantage plans receive a payment for each member from CMS, and CMS is the Center for Medicare Medicaid Services. What this means is, instead of being paid a certain amount of money to take care of a group of people, the amount of money that you get paid is based on the need of each individual member. And so that has to be calculated. So payment is based on each member's predicted health status and demographic characteristics. So it depends on their age, sex, whether or not they have disabilities, that sort of thing, but also their health status. And again, Medicare Advantage is regulated by CMS. CMS pays Medicare Advantage plans and prescription drug plans, which are part of the Medicare Advantage program, by adjusting payment for enrollees based on their demographics and their health status. This risk adjustment payment model measures the disease burden, so you get paid more if the patients are sicker. So to measure that disease burden, accurate diagnosis code documentation, ICD-9s, and reporting now determine the reimbursement. So it is very important to accurately code and document everything going on with the patient. So let's look a little bit about risk adjustment. So risk adjustment, it's a payment methodology used by Medicare Advantage health plans to adjust health plan payments based on the enrollee health status and demographic characteristics. They use the hierarchical condition category model. That's the HCC. So if you wanted to know what that stood for, that's it, hierarchical condition category, and we talk about this in the lecture series, in the videos. A risk score would be equal to the demographic factors plus the HCC codes. So what is a hierarchical condition category in HCC? It is a category of medical conditions that map to a corresponding group of ICD-9 diagnosis codes. So there, in the 2014 model, there are 2,913 ICD-9 codes that map to one of 79 HCCs. So with the implementation of ICD-10, number of codes and mapping will be more extensive and complex, needless to say. Now, what is risk adjustment? CMS risk adjustment takes data from a large pool of Medicare beneficiaries to estimate average cost in order to adjust payments relative to the average Medicare beneficiary. And I might say that they use a lot of fee-for-service Medicare members to come up with this large pool to know exactly how much it costs to take care of Medicare patients. So risk adjustment is used to determine the amount of money that CMS pays to Medicare Advantage health plans. So Medicare beneficiaries with lower than average predicted cost have their payments decreased to their plan, and Medicare beneficiaries with higher than average predicted cost have their payments increased to their plan. So here in Tennessee, where more people are sick, we would tend to be paid more in our plan than people in Utah, where people tend to be less sick. So how does this work financially? So a risk score of 1 represents the average Medicare patient. So you average them all together, all the risk, and you consider the very center, the average, as being 1. And CMS pays a premium per member per month of about $800 a month. Now, this is not an exact number, and it can vary from place to place. But this is based on the fact that it takes about $9,600 a year to take care of the average Medicare patient. Now, keep in mind that cost also includes inpatient, outpatient, medicines, lab, x-ray, plus the administrative cost of the insurance company. So if you take that and you look that if 1 point or 0.01 would be equal to 1% of average premium per member per month. And let me show you where I'm going with that. Now, if you look at the average patient, risk of 1, they would receive around $800. Now, what if the patient is a little bit healthier? So if it's a little bit healthier, let's say 10% healthier based on the risk scores, the risk might be a 0.9. And in that case, the insurance company would receive 10% less money to take care of that patient. So they would get a premium of $720. But what if the patient is a little bit sicker? Let's say 10% sicker. So they would have a risk score of 1.10. And in that case, the premium would be $880, which is 10% more than the average, which is $800. So if you are healthy, you get less money in the system. If you are less healthy, there is more money in the system. So now let's kind of see how that works. So this is what we call the medical expense ratio, and that is you take the premiums minus the expense, and essentially what you have left over is profit. So how do you get the premiums to go up? Well, making sure that you code properly, your risk scores will improve, but you must have knowledge of HCC coding to do this. Also, some Medicare Advantage plans actually charge a premium to the members, and so that will also increase premium. Now, you also want to decrease expenses. Now, that does not mean that you give people less care. Really, it's quite the opposite. What you want to do is remove waste from the system, and most of the waste is through unnecessary emergency room visits and unnecessary hospitalizations. And how do you prevent those? Well, you increase quality of care, you do better follow-ups, you have more availability, so you actually take better care of your patients to reduce expenses. And so if you are able to increase your premium and decrease expenses, that leaves more profit in the system. Now let's take a patient and see how this works. So this patient is an 85-year-old white female who has symptoms of urinary tract infection. This patient has mild malnutrition, she's frail, and she's lost 30 pounds in the last 6 months. Urinalysis performed shows that she has white cells, leukocyte esterase, and microalbuminuria. Serum creatinine is 1.4. The patient has been complaining of urinary discomfort, weakness, and has had dry and itchy skin for the last 6 months. Now, past medical history. She has stable diabetes mellitus. She has chronic kidney disease exacerbated by diabetes. She has a stable below-the-knee amputation. She has a history of having had a urinary tract infection with a serum creatinine of 1.3 6 months ago. Her lab findings revealed that she has chronic kidney disease stage 4. So how do we treat this? This patient was treated with glipizide 2.5 milligrams daily for her diabetes, Cipro for the urinary tract infection, and Glycerna for her malnutrition. She was to return to the clinic in 3 months, and she was referred to a nephrologist for chronic kidney disease stage 4. Now, let's talk about coding dysfunction a second. Coding dysfunction is a condition in which a medical provider improperly codes a patient's health conditions. This usually involves undercoding the medical problems in intensity, meaning that they code something less severe, and/or quantity, which means that they are not coding all the chronic conditions. Let's see how this comes into play here. In this patient, if the provider has coding dysfunction, he might code this patient like this. Diabetes mellitus, ICD-9 code 250 is the code for uncomplicated diabetes. CMS risk score would be 0.118. The patient came in with a urinary tract infection, and this is ICD-9 code 599. Now, this has no associated risk score because urinary tract infections tend to be self-limited, and after treated, they go away and hopefully stay away. So in this patient, the way she was coded by the provider with coding dysfunction. She had a demographic score of 0.44 due to her age and sex. You add that to the risk score for diabetes without complications, and you get a risk adjustment factor score of 0.558. Now, if you multiply this by $800, you would get a monthly per member per month payment of $464. But now, what if this patient was seen by a very informed medical provider who understood all the rules with HCC coding? He would know that this patient did not have diabetes without complications. She had diabetes with complications. She had renal manifestations of her diabetes. And this is ICD-9 code 250.40 and has a higher risk, as you can see, from 118 to 0.368. Now, again, the urinary tract infection would have no risk associated with it. He also coded 2 kidney problems. He coded the diabetic nephropathy, which the patient had, but he also coded the stage of the chronic kidney disease, stage 4. Now, when you look at HCC coding, part of the hierarchy has to do with some diagnoses in the same category will trump another diagnosis. And so you'll learn more about that in the video series. But in this case, there is a higher risk score with chronic kidney disease stage 4, so it is 0.244. He also recognized that this patient had a mild degree of malnutrition. This is rarely documented and rarely coded by physicians and providers. But this doctor knew that that was very important in the HCC model. So he gave her code 263.1, and it has a very significant risk score of 0.713. Also, amputations that are stable, again, are rarely documented by providers, and if they are, they're certainly not documented yearly, and you'll learn why documenting yearly is important when you watch the video series. But below the knee amputation, V code 49.75 has a very significant risk of 0.779. So you add all these risk scores up along with the demographic score, and you will find that this patient has a risk score of 2.544. Now think about this. The way that the provider with coding dysfunction coded, this patient was almost half as sick as the average person in the Medicare Advantage plan. And the way this person coded the person, and everything here is accurate, she's more than twice as sick as a person in the plan. And keep in mind, this is not gaming the system. This is how the system works. You know, by saying that you're gaming the system by doing all this is like saying that you're gaming a football game, gaming the system if you kick a field goal instead of going for a touchdown. No, that's just how the rules are. And the rules with HCC coding are like this. These are all very legitimate diagnoses in this patient, very important to document, and very important to code properly. So in this particular way of coding, the patient would receive, or the insurance company would receive, $2,035 per month to take care of her medical needs. Now keep in mind, this is inpatient, outpatient, and everything going on with this patient. So the difference is $1,571 per month coding properly versus coding improperly with this patient. Now multiply this by 12, and as you can see, you'll get well over $18,000 difference per year by just coding properly. Now think about that. That's a significant amount of money on simply coding one patient properly. So what are the causes of coding dysfunction? Well, in my experience, we have apathy, they just don't care. Poor time management, that's usually the biggest thing I hear is I just don't have time to do that. Also, you have failure to understand the importance, ignorance of coding rules, does not believe it helps take care of the patient, does not relate coding to the financial health of his organization, and has difficulty understanding the difference between fee-for-service and fee-for-value. The video series cannot do anything about apathy and poor time management, but it can certainly do something with all the other causes of coding dysfunction. Educated physicians who understand the importance of HCC coding in a Medicare Advantage plan can't be understated. This quote came from Modern Medicine, and that is that the best practice in disease management saves maybe $200 per Medicare life. Best practice in coding achieves a $2,000 increase in reimbursement through identifying correct coding. You really need to hit this from both sides. You need to take better care of the patients to decrease costs, but in a Medicare Advantage plan, you have to code properly or you won't get proper reimbursements to take care of the patient. Sir William Osler said, "He who knows syphilis knows medicine." What I say is, he who knows HCC coding knows modern medicine and risk adjustment. Now, the video program HCC Coding for Medical Providers, you will find how to get more information on that on the website HCCCODING.COM. But it is a streaming video series of lectures. It's about 6 hours long. It covers all sorts of topics such as the history of risk adjustment, Medicare Advantage plans, why HCC coding is important. I go through each HCC in the body systems. I go through what are the most common dysfunctional coding patterns that I see and how to correct those. Right now, we will be giving credit through CME Outfitters, and they are helping me with this video program. So if you want to know more about HCC coding for medical providers, go to HCCCODING.COM. I will say that this may be one of the most important CME programs that any doctor or provider in a Medicare Advantage program can see. Thank you.